Neeraj?
Good evening, everyone. We welcome you all to Ortho TV Online. To introduce today's program and the speakers, I hand over to the Oref Chairman, Dr. John Mukhopadhyay.
Good evening, everybody, and welcome to this webinar today. Today, we're going to have two talks, one by myself and other by Dr. Coxon Kong from Singapore. Just a brief introduction about Dr. Kong. He has been, he's a very good friend of mine, and we've been together in various courses for many years now. And it's a real pleasure to have him to give this series of lectures, which we'll be doing over the next 2 months on pelvic and acetabular fractures. Coxon was actually trained in oncosurgery as well. So his knowledge of anatomy is what has really helped him in his career, especially with pelvis and acetabulum, which needs a lot of dissection through areas which can be quite difficult to manage if you don't have the exposure to that surgery. So he's presently at Singapore and working there. He's recently moved to a new hospital. Well, it's no longer recent, some years ago. And it'll be a pleasure to have him with us together on this talk. These series of talks are basically aimed at postgraduate students, DNB and orthopedic postgraduate students, and also young orthopedic surgeons in the beginning of their careers. So they will start from fairly basic concepts of the management and anatomy, radiology, etc., of both pelvic and acetabular fractures. So I think without much further ado, I will hand over to Coxon, who's going to do the first talk, which is on the basic anatomy and sort of assessment, or not the assessment, but of pelvic fractures. So he's going to talk about pelvic fractures, basically.
Okay, good evening, everyone in India. Greetings from Singapore. I'm very honored to be included with Dr. John Mukhopadhyay, who is probably one of the best teachers I've come across. And I hope to emulate his teaching, and I will try to share what I know. I understand that being postgraduate students, I'm dealing with people in different years of training. So I will try to keep it as simple as possible with a lot of graphics and with as little references to literature, which I'm sure you all have full access to. This is more of an overview and to try and keep it simple and easy to understand. Okay, so my topic, let me share my screen. My topic tonight is, in the first week, will be functional anatomy and radiology of the pelvic ring fractures. So we will go from the ring, then we will discuss the acetabulum in the next few weeks. The basis for management for all pelvic and acetabular fractures remain an understanding of the bone morphology and the anatomy. To understand what the pelvis is, it's not like a simple long bone. And to achieve complex fracture reduction, fracture which also includes joints like the sacroiliac joint, the acetabular hip joint. And because of the complex three-dimensional picture, it is, if you don't understand these patterns and the methodology, then there's a high chance of failure. Then where do we apply fixation implants? The pelvis, as we know, is made largely cancellous bone, but there are buttresses and there are empty spaces. So the understanding of the anatomy allows one to place implants at a proper place for proper function. Also, if you use the implants properly and they hold in time, the pelvis actually heals quite fast, and you can accelerate healing and recovery with proper rehabilitation and not just rely on bed rest after surgery. The bone, as I mentioned, is largely cancellous and it contributes to blood loss. So because there's a big well reservoir of blood. So fractures will cause bleeding and shock. You have to identify from the anatomy as well as 3D scans where the strong pillars are for fixation. And with compression, which I rely a lot in the pelvis and in cancellous bone, the healing is very fast. However, we are seeing patients who are now osteoporotic, and of course, fixation will be less effective than in the younger patient. So again, using these strong pillars will allow one to achieve the function and recovery. It's a large complex architecture and cannot be exposed by one single incision. So you have to decide whether you can approach which one. You have to plan very well which fracture or which part of the bone to approach, and whether you need second or even third incisions. It needs a 3D visualization, and because of the complex nature, there are potential soft tissue contents which are at risk of injury, particularly, for example, the bladder and the nerves around the sacrum. If you don't treat them, and many I think are not treated maybe with conservative treatment or with traction, it is common for malunion to occur, and especially in vertical shear cases, there will be limb length discrepancy. So the pelvis acts as a cantilever system for gait, and you have to have equal height, and it's sort of like a cantilever effect. So the restoration of this anatomy allows for balanced gait and reduction of limb, and also reduction of problems with the lumbar and the spine. It's a large anchor for locomotor muscles, so it means that you have to go through some of these muscles in order to reach the bone. As I mentioned, it protects reproductive organs, the fetus. Sometimes you may have to handle a case with a pelvic fracture in a pregnant woman. It's also a source of hemopoietic tissue and bleeding, as I mentioned. One thing is that the bone, although complex, are generally held together in a ring formed by ligaments. So the ligaments are an important structure that helps to maintain the anatomy. In one bone or in one ring, you can undergo compression, tension, or shear forces. And so you need to know when to apply screws, plates, and when they can be used in buttress and in compression or even in tension mode. And you can put implants in cortical bone. You can apply greater compression than in the cancellous bone. So choose those blue areas you see on this diagram. These are the cortical buttresses that can fit in implants in compression mode. The ligaments are many, and in the inlet you have the sacroiliac ligaments at the back, anterior and posterior, and the symphysis in front. So if you can get this picture of an inlet and outlet, you will know what pulls and what pushes, and what happens when ligaments are torn and the deformity occurs. So in the back, you see the sacrotuberous and sacrospinous ligaments, important in order to achieve reduction. And then in the back, you have the iliolumbar and the posterior sacroiliac ligaments. Iliolumbar is stronger than the transverse process, and one of the pathognomonic signs of vertical shear is the avulsion of the transverse process of L5. If you have a dislocation as opposed to a fracture, you will see that it takes longer to heal, and therefore you have to be more robust in fixation. So larger screws, for example, the sacroiliac joint, you cannot put small screws 3.5 through the sacroiliac joint. I generally use 7 or 7.3 screws because it is a joint dislocation, and ligaments take longer to heal. And reduction, secondary loss of reduction is quite common for these dislocations. If you get a dislocation and malreduction, you can get post-traumatic pain, which may need to make you consider a future, or at the time of injury, a fusion of these syndesmosis. Okay, let's have a look a little bit about the pathomechanics of injury and how it affects the pelvic ring. In the AP vector, in the AP force, you see anterior lesions due to the fact that you are doing the open book, and then you get adduction, flexion, and external rotation. And what happens is that you have increased the volume of dead space. If bleeding occurs, it can result in shock stage. The lateral compression vector is a second form of force. What you see forces directly hitting the patient or the victim from the side, either through the iliac crest or indirectly through the hip joint or the upper part of the femur. The forces will then, in this finite element study, transfer towards the acetabulum and then the rami and then the SI joint. So you see patterns of fractures that include compression. So you can see that the ring is unequal, and you can see compression fractures, marginal fractures, and also fractures of the anterior, posterior rami and back. So if you have displacement in any of them, there will be at least 2 breaks in the ring in this pattern. Vertical shear forces, the force will be vertical, and it can either be hitting the ischial tuberosities or onto the lower extremity through the hip joint. And there's also a rotational element in this study also of forces applied to the pelvis. You can see shear forces are affecting the anterior superior part of the ala, and therefore injuries there as well as dislocations and disruptions will occur. And it's centered around the S3 body, where it's the center of gravity for the patient's body. So it's you can tell that it's the rotational forces. So that leads us to ask if open book and vertical shear are related to each other. So if you look at this diagram, and you have the ligaments intact, if you have an open book, it's in single plane. That means it's adduction, external rotation, as we call it. But there's also, because of vertical loading, an effect of vertical translation and torsion of this pelvis. And so if you see a picture like this and a fracture X-ray like this, it has both the vertical component as well as the external rotation component. So in many ways, they may be related to each other, and the displaced hemipelvis can be reduced in both internal rotation and in flexion. Okay, for the second part, let me go through the radiographs. The plain radiographs, the standard radiographs that are used in X-ray evaluation of these injuries. The first one is an AP X-ray, and usually taken at the emergency room, and probably taken before you arrive if you are called on to see the patient because they have other injuries. Taking an outlet view about 45, sometimes 40 degrees capillate will let you see the height of the iliac ring, and also a good view of the whole body of the sacrum, and any displacements medially usually or laterally of the hip joint. And in the inlet view, you can see very clearly disruptions of the anterior and the posterior elements of the sacrum, of the pelvic. How do we interpret this plain radiograph? So let me just take you quickly through the ways that I use if I see these type of injuries. So let's go injury by injury. The first is the AP compression injury. First, what I like to do is I like to level the pelvis. So what we do is we find out where is the midline. So that's the middle of the sacrum, and it should bisect the symphysis pubis. Then you ask yourself, is there a radiographic marker? And the radiographic marker is often at the side here. If you can see it, you can use this to measure distances and dimensions. Then look at the symphysis distance first, and in the open book, we certainly expect some opening, but sometimes it's hard to tell which side is open. Both sides are open, or one may be internally rotated and one externally rotated. So if they deviate laterally from the midline, you have an open book. So you can measure 18 millimeter is certainly displaced and 28 is clearly displaced. So what I do, I have a picture of, I mirror the pelvis. In this case, of course, you see the fracture here. So you mirror the pelvis on both sides and you try to replace, see where the distance is, where the symphysis should be. Look at the sacroiliac joint and see if there are any breaks in the bony outline. So you can see it's hard to see in this case, but there is a suggestion that because of the displacement anteriorly, there may be an opening of the anterior sacroiliac joints. It's probably best seen finally on the CT scan. When you look at the breaks in the bony outline, look at the iliac crest, look at the pubic symphysis. In this case, the pubic rami is fractured. And then the sacrum, and look at all the foramina in the sacrum. In this case, you see a very nice view of bones because there is very little gas in the bowel. But sometimes if you have plenty of gas, it can be very difficult to make out what is a sacral foramina and what is a bubble of gas. In lateral compression, we level the pelvis, so you straighten the pelvis out. And we ask ourselves again, where is the midline? So always come through this same routine, and then you can see that in this case, the symphysis has been displaced medially on the right, and the left is intact. Look at the hip displacement. You can measure the medial part of the hip comparatively, and you can see that this hip is more medialized than the left side. Look at the sacroiliac joint, and you see the sacroiliac joint right here. You can see a parallel line in almost every view, but over on this side, you will see that there is some very little there's overlap. So you really cannot see. So you suspect a disruption at this time. Breaks in the bony outline, again, go through your iliac wing, you go through the pubic rami, and then the sacrum. Sometimes sacral foramina may be seen or may not be seen. Then you review your trauma mechanism, and you suspect this is a lateral compression. Just check again with the patient. There may be wounds on the side of the pelvis, on the side of the lateral compression. That confirms the assessment of the personality of the fracture. In vertical shear injuries, again, ask yourself where is the midline, level the spine, and look at the iliac crest levels and also the hip joint. You can see that there is a discrepancy. And then you look at the symphysis. The symphysis is totally in the midline. So there's no, it appears to be an external rotation, but actually with the pelvis in the middle is probably a vertical displacement. Look at the sacroiliac joint again, and then you can see the breaks in the bony outline. And in this case, you can see a further crack in the whole wing. So this, in a crack here with a sacroiliac joint disrupted, is typical of a crescent fracture. Sacral foramina here you cannot see because of the blood in the pelvis. And look for this pathognomonic sign of an avulsion of the L5 transverse process on the same side as the vertical shear. That confirms the instability pattern. Again, review the trauma mechanism and you will come to a conclusion and assessment. What about the CT scan? So actually, what I do is I always read the X-rays first. These are the standard 3 views of X-rays. I always read them first, try to get in my mind personality of this fracture. And if you look at this, okay, now you're looking at small, you can see certain cracks, but you're not sure what's happening at the back. And then the CT value is in the reading of the posterior injuries. Then look at the 2D cuts. So you can clearly see this you will not see on a plain X-ray. So a Danny type 3 fracture into the spinal canal of the sacrum. Some 3D pictures are very nice to see, but actually what you need is a 2D picture to give you a very unequivocal injury, especially if there is a neurological deficit. What I do is when I use the 3Ds to transpose these injuries onto a plastic bone model so that you can draw this on your plastic model and then you can bring this to OR and then you can learn from there what it looks like on the body. So it gives you a 3-dimension picture when you are doing the surgery. And they also, you can plan what you want and you can use, you can choose your plates. If you have the special plates that have to be bent we can bend them on the model first and then autoclave them for use in intraoperatively. So the take-home message I have is you must be familiar with the three-dimension anatomy. And I always use a bone model even today, just to teach as well as to refresh myself and not get into trouble when I don't do it too often. Get very good standard radiographs and CT scans. I think CT scans, everybody jumps to the CT scan because they give good pictures, but always have good standard radiographs because this is what we're going to do when you do intraoperative check radiographs. You can only do it on a fluoroscopy on plane, and you don't have a CT intraoperatively. And then identify the vector and look at the instability pattern and also the associated injury patterns. Angiography and urography can be done in individual cases, and they're usually in conjunction with other specialists. Then you aim for temporary and then later on definitive stabilization based on what you understand, the personality and the pattern. Thank you so much for listening.
Thanks a lot, Coxon. That was great. We can take a few questions now for 5 or 10 minutes, and then we can do questions again at the end of the second talk. So one of the issues, Coxon, with the X-rays initially is, especially in the multiply injured patient, it's sometimes difficult to get all these views initially. So I think, and also to get good X-rays becomes quite difficult. So how do you manage it in your own setup?
Yes, I think when there is a suspicion of a pelvic injury, the three views are taken, and sometimes we even add the oblique views, the Jude views, because we damage the injury. So we take 5 shots as a standard protocol, because sometimes you do not know when the patient is stable enough to go for CT scan. On the other hand, it could be that the patient is in some units where they have the CT scan next door to the ER, they get a helical CT of the whole body because now the general surgeon, the neurosurgeon, thoracic surgeon, they want to know what are the other injuries. And so you get a CT scan of the whole body from which you can then study what you want, and then you forget about the X-rays because you say, I understand what I see. The only problem is that those helical CTs of many slices, they are very thick. So you can't repeat using them to do your planning because the slices are quite thick and there's no overlap. So their resolution is not so good, but it's good enough to pick up injuries. But I still always teach people to look at the X-rays. You may not get it on the first go and having with all the business of resuscitation and all, but somewhere along the line, with or without external fixators or C clamps on, you will still need to get some idea of the X-rays because when you go for surgery, you only have the fluoroscope, and that gives you the equivalent of an X-ray. And if you didn't see the X-ray before, you'll be trying to work your mind from a 3D of anatomy of the pelvis into a 2D one, which then can give you problems of not understanding where the directions are for implants.
Yeah, I think I agree. I keep trying to get my residents to make sure they get all these X-rays, and it's often quite a difficult job to get it from them. But certainly before we take them to OR, we definitely want to get all these views because at surgery, these are the views that you can check again to know whether you've reduced it compared to your pre-operative films, etc. So I agree there. Yeah. Any questions from any of the students right now?
Not yet, sir. One thing which I want to ask, one common question which is usually asked during the exam or during the classification also about the rotation. It is internally rotated or externally rotated. So on the basis of X-ray, how we can say that the pelvis is internally rotated or externally rotated?
You mean the whole pelvis?
Yeah.
Okay, most of these X-rays, as I say, should be done in the totally neutral position. So if you get rotation in its original position, so the patient is not centralized, you may have an issue with trying to find out where is the midline. So I would make sure that when they do X-rays, the pelvis is level. Of course, there are the bone may be displaced, but the patient should not have a pillow under the chest on one side or the abdomen. So they should be lying flat supine on a gurney or on the resuscitation table when you do the X-rays. Then you can read, as I mentioned, whether it's an internal rotation or external rotation pattern of the fracture. So you don't want to confuse yourself by having a uncentered patient.
Okay, so
yeah. One more thing which I want to ask for a pelvic trauma, it is always needed for a 3D CT scan, or just 2D CT scan is also okay for?
2D and 3D can be obtained at any time. It's a software issue. So very few people order plain 2D and I said and tell them I don't want the 3D, because the 3D can be done automatically. So all you need is a good CT scan radiographer. He can give you the 3D pictures as fast as he can give you the 2D, because it's just generated by the machine. What you may want to do is to actually go into the radiography suite after the 3Ds have been reformatted, and then move your cursor to rotate the pelvis to understand where the pattern is, you know, the displacements and all that. Because sometimes they give you a few standard locations. But if you go in and play around with it, you can tilt it in any position you want using the cursor.
Yeah, so I think the 3D really gives you a very good idea of the overall displacement of the fractures. But for details of the fracture patterns, say like if you want to look at the sacral fracture in detail, you really need the 2Ds to be able to assess the fracture more closely. The CT gives you a very nice overall picture, shows you where the overall displacement is and stuff like that. But to really look at the minor details of the fracture, you need the 2D scans.
Yes, especially when there are small intra-articular marginal.
Exactly. Yeah.
You cannot see it on the 3D unless you remove, say, the femoral head, and that takes a bit of time. But on the 2D, you can see it straight away.
Sure. And even if you do the subtraction scans, you kind of get a more, it's kind of the minor details are blurred in the 3D.
Exactly. Yeah.
So one question from Ratnesh sir, he want to know, do you use 3D printer also?
Okay, probably in some sort of reconstruction, but if you're talking of 3D printer to create a model that from which you are going to do your testing, or your dry bench type of practice, I don't do it, but I think if you have the means, it's certainly good as a learning prospect, and also to teach people how you would approach this on the bench. Yeah. But you can do this later, but I wouldn't do it on just for the care of the patient, but for the training and the motor skills, it may be good to have those things.
And maybe for some late reconstructions, it would be useful, say.
Yeah, malunions, I think they are perfect for malunions, because in malunion there's no textbook. You have to learn from what you get, and then you try to reconstruct the best you can by trial and error. So better to do it on the bench than to do it on the patient.
So I think I may request John sir to have a lecture, so
Coxon,
and after that.
Coxon, if you can stop sharing, then I can share my.
Yeah.
Great.
Yes, go ahead.
Yeah. Okay. So I'm going to talk about the basic assessment of these fractures and also go on to the classification. So I think one of the important things in pelvic fractures is to understand that you hopefully by the end of this talk, you would understand how to assess these fractures, decide which patients need emergency life-saving procedures. We're also going to learn the basic classifications and use this and your initial assessment and findings and the radiology, which Coxon talked about, to plan your definitive treatment. Remember, these are words of Marvin Tile, who said that pelvic fractures bleed to death, while acetabular fractures limp to their death. Okay, so it's important to understand that these injuries can cause severe hemorrhage, and you need to really assess them in terms of their stability, both the bony and hemodynamic stability. You need to assess the amount of blood lost. And also, they very often have associated injuries, which could be contributing factors to the morbidity and mortality, which you need to really look at. So when you have injuries with so much displacement on your x-rays, you really need to also make sure that there are no other injuries like in the chest or abdomen that you're missing out, which could compromise what is happening with the patient. So what is the significance of these injuries? I think if you look overall in all fractures, probably they constitute about 3 to 8% of all fractures. But the moment you start getting multiply injured or polytrauma patients, the incidence of pelvic fractures rise to almost 25 to 30%. The overall mortality of a patient with a pelvic fracture, this is, we are talking about displaced, not just crack fractures in the pelvis, is 8 to 15% mortality. And if they're complex, severely displaced injuries, it goes up to 20%. And in open pelvic injuries where you have a bladder or a rectal injury, especially, or bowel injury, there the incidence is as high as almost 50% in some of the studies. Okay, so whenever this multiply injured polytrauma or a significant pelvic injury patient comes to you, you have to first go through the ATLS protocols. And I think you're all familiar with them. You need to look at the airway, the breathing, the circulation, make sure you do the cervical spine clearance, splint any obvious fractures. You need to avoid further injury. So whatever movement you do of the patient should be kept in mind with the idea of avoiding further injury, especially for the spine. The other things that you need to evaluate in the initial assessment, whether they need urgent transfusion, the severely injured patients can have problems with their coagulation profile. You need to make sure their body temperature is maintained, they don't go into hypothermia. You need to look at the urine outputs and also their response to resuscitation. And I think we are going to go into the details of the pathophysiology of major trauma in more details next week. So I'm not going to dwell on that too much. Remember that conventional science may be sometimes unreliable. So that's why you need to check your arterial blood gases, your biochemical markers, especially serum lactate levels. If you have access to IL-6, that is also helpful. And be aware of the concept of occult hypoperfusion, where even though the patient may be stable, he may be not getting adequate oxygenation of his tissues. So any patient with pelvic injuries, you also need to make sure you look at the chest. So that involves a clinical examination and auscultation to check that the air entry is adequate. And on both sides, you need to look for any flail segments, paradoxical respiration. You need to get a chest X-ray, obviously, look out for any pneumothorax and pneumothorax. And today, HRCT is what people would go to fairly early to rule out any significant lung injury, contusion, or any hemothorax or pneumothorax present there. Now, it's important that we do this not just in the preliminary assessment, but it needs to be done regularly during the stay of the patient, especially the initial 48 hours or so. So you have this patient with this pelvic injury and the initial chest X-ray looks fine, the chest oxygenation, etc. was fine, but next day you could see that his respiration rate was increasing. He had more dyspnea and his oxygenation levels were following. And then the X-ray shows there's more mottling and some sort of shadowing on the right side, and the CT showed you this huge hemothorax there, and therefore he needed a chest tube to drain the hemothorax to settle him down. So I think it's not just your initial assessment, they need to be assessed regularly to make sure that no significant collection is taking place in the chest, abdomen, etc., which may not be there in your initial assessment. Okay, so any hemodynamically unstable patients, of course, you look at the pelvis, but also look for any other source of injury. So you could have an open wound which can sometimes bleed a large amount. You can have bleeding into the abdomen, into the chest. Today, you have the ability to focus ultrasound as well as HRCT to rule out any significant collections or injuries in the abdomen. Long bone fractures, especially significantly displaced femoral fractures, can bleed a lot, and sometimes if there's delay in bringing the patient in, a lot of, or in splinting the femur, a lot of blood loss can take place in these. If the source is pelvis, remember, massive blood loss is usually venous, not always, but usually venous, and usually due to posterior disruption and the enlarged compartment of the pelvis, especially in anteroposterior injuries as well as vertically displaced injuries. So I think you need to watch out for that. They would need some kind of stabilization. You need, today the binder is what is used initially for most of these patients. You need to assess these patients once for stability of the pelvis. You can't keep doing this again and again, but because very often these patients have binders on when they come in today, it's good to just examine once to look for any obvious instability in the pelvis, but avoid repeated examinations. You need to check for any obvious injuries to the urethra. Is there any bleeding around the meatus, any bruising in the abdomen or in the suprapubic region to suggest bladder injury, any vaginal injuries, any injury to the sphincters and prostate, and also around the rectum to make sure that there are no injuries that you're missing there which can cause problems later. The other thing to watch out for is Morel-Lavelli lesions. Again, this is something, is a developing thing. You will have fluctuation of the soft tissue, sort of soft fluctuant areas in the skin with a sensation that there's some fluid underneath it. There could be bruising, localized hematoma. Often the sensation in that region could be reduced because there is a degloving of the skin from the underlying tissue. So I think this is something which is often there with very severe pelvic injuries, and something again which is not so infrequently missed. So I think we've seen these being missed and then resulting in major problems or disasters later with breakdown of the skin, infection, and then it takes a long time to deal with these problems. So as was mentioned earlier, in the initial sort of ATLS protocols, you get a single AP fill. And this can actually tell you a lot, and you probably miss only about 9% of significant injuries. And it doesn't change your acute management much. So if it's a significantly displaced or severe injury in the pelvis, your initial management would be based on an AP X-ray. And the other views would be done when the patient is a little more stable. Again, like you can have a helical CT of the entire body in the emergency department today, but if you want to get details of the pelvis, you would need to get a CT scan done when he's a bit more stable. So then we come to the classification. I think the classification is important if it helps you in predicting hemodynamic stability, helps you in predicting visceral and genitourinary injuries, aids in predicting pelvis instability, aids in understanding mechanisms of injury, force vectors, etc. of injury. And I think some of this was covered in the previous talk. And if you can understand the force vectors of the injury, it would also help you in planning your surgical tactics for reduction. So the classifications, I think there were some early classifications which were entirely anatomically based on what bones were fractured. But today, there are two major classifications which are often used. The Young Burgess classification, which is probably the one used still most often, and that by Marventile. And then you also have the AO-OTA comprehensive classification, which we will go through briefly. So I think the Young Burgess classification is probably one of the most commonly used classifications. And here, as you can see, the injuries are defined into the lateral compression or implosion injuries. And again, a lot of these lateral compression fractures, if it is a low-grade injury, often are not very unstable injuries, while The AP compression fractures, usually you get separation of the pubic symphysis. The vertical shear, as was mentioned earlier, you often get displacement upwards of a hemipelvis, while the really severe injuries are often combined. So you have a combination of mechanisms of injury, and it may not always be possible to identify a single mechanism of injury in the really severe injuries. Now, the lateral compression fractures are again classified into 3 grades in the Young Burgess classification. You have the LC1, LC2, LC3, and I think this is based mainly on the posterior injury, the classification. So if you have a compression fracture of the anterior sacrum only, then it's a LC1. If you have an iliac wing fracture posteriorly, which is unstable, and usually this is in the form of a crescent fracture, which involves the SI joint, then it's a LC2. And very often, if you have a windswept pelvis with a contralateral SI injury, it would be an LC3. Similarly, the anteroposterior compression injury, APC1, is a partial disruption in which only the anterior part is involved. And usually, initially, it used to be said that if the symphysis is separated less than 2.5 centimeters, it would be an APC1. If it was between 2.5 and 5, it would be 2. And if it was more than 5, it was 3. But it's really more dependent on whether the posterior ligaments are involved, and if the anterior part of the posterior sacroiliac ligaments are involved, it becomes a 2. And if both the anterior and posterior parts are disrupted, then it becomes APC3. Of course, we have the vertical shear and the combined mechanisms of injury, which are more severe grades of the injury. So you can see LC1 with an anterior sort of compression fracture of the sacrum, LC2 with this fracture of the iliac bone involving very often the SI joint, and LC3 where there's also a contralateral injury, and APC1 where only anterior involvement is there, APC2 where the anterior part of the posterior sacroiliac joint is involved, and APC3 where even the posterior part of the sacroiliac ligaments are involved, and vertical shear where there's vertical instability because there's vertical displacement of one hemipelvis. It's interesting that if you look at which of these patients need resuscitation most often, that means significant blood transfusions or management in terms of saving their life, it is the LC3, the APC2 and 3, and of course the vertically shear injuries and the combined mechanisms. So here are X-rays and CT of a lateral compression injury. Again, you can see that the vector is probably from the lateral side here. You can see the SI joint, the AP joint is displaced towards so if you draw the midline as was mentioned by Coxon, you see this pubic symphysis is displaced medially, and you can see the fracture in the sacrum on the same side. The AP compression, or where you have an open book type of injury, again, you can see the wide displacement of the pubic symphysis here, and you can see here there's involvement of the SI joint, which is opened out but not displaced vertically. Okay, so and the vertical shear injury where you can see an obvious displacement of the entire hemipelvis along with a fracture in the sacrum and a disruption of the pubic symphysis here. So that would be so the tile classification is based on the stability of the fracture. So if you look at the pelvic ring, a type A fracture would be one in which the pelvic ring is still stable. Type B is what we call partially unstable or partially stable, where you have rotationally instability but not vertical instability, and type C are those which are both vertically and rotationally unstable. And this stability, again, as mentioned earlier, is dependent mainly on the integrity of the posterior weight-bearing sacroiliac joint complex and the pelvic floor. So the symphysis tear has actually very little influence on the stability of the pelvic ring. The moment the forces go and disrupt the ligaments posteriorly, it becomes more unstable. And when the posterior part of the ligament or the entire ligament complex is disrupted both anteriorly and posteriorly, then they become maximally unstable. So the other point that was brought about is very often if you have injury on one side of the ring, you will also see injuries on the opposite side. It's very rarely an isolated anterior or posterior injury, and this was shown by bone scans as well as autopsy studies in the following studies. So coming back to more details on the tile classification, the A, which are A1, which are stable injuries. The A types are A1 is avulsion of bone, A2 is stable iliac wing fracture. So very often we have patients with iliac wing fractures or sometimes involving the anterior superior iliac spine. And often these are not unstable pelvic ring injuries. And similarly, transverse fractures of the sacrum or coccyx will not affect the stability of the pelvic ring. We come to the B type injuries. So the B1 is the open book injury. B2 are the lateral compression injuries. And there B2-1 is ipsilateral type of lateral compression injury, while B2-2 is a contralateral type or a bucket handle type of a lateral compression injury. And B3 would be bilateral unstable injury. So if you have unstable injury or B-type injuries on both sides, it would come as B3. Okay, so here's an example of a B1 type of injury, open book injury. You can see there's involvement with the displacement of the opening out of the book with the separation of the symphysis pubis. And you can see there's one-sided involvement of the SI ligaments on the right side here. So, okay, so sometimes you will see this slight sort of kind of appearance of vertical displacement, but you need to look really at the posterior joints and you can see that there's no displacement. This is because of a slight rotation during the taking the x-rays. Okay, so this is a rare blocked symphysis where you get a compression injury, lateral compression injury, and the symphysis gets locked here. You can also have a posterior injury here, it's on. So this is something that you need to actually physically unlock. Sometimes you can use an external fixator to unlock it, but often need surgery to get this back into position. And then you have the C1 types, the C types, where C1 is C1-1 is when the ileum is involved, C1-2 is the sacroiliac dislocation or fracture dislocation, and C1-3 is where the displacement is through the sacrum. So these are unilateral injuries, come as C1. C2 is bilateral, where one side is a B type. That means it is vertically stable, rotationally unstable. One side is C. And then the C3, where both sides are rotationally and vertically unstable. So this is probably the most severe type of injury. So here's a type C injury. You can see that there's a crescent fracture on the back here and an injury here and a vertical displacement of the entire SI joint with this crescent fracture of the iliac posterior part of the ileum showing a posterior displacement. If looking at the inter-observer reliability of the Young-Burgess and Tile classification, there's a few studies which shows that probably the Young-Burgess has a slightly better reliability, especially in training of surgeons, and the CT improves the assessment of stability. And again, this inter-observer and intra-observer sort of study for reliability study seems to be better for the Burgess than for the Tile classification. And finally, we come to the AO-OTA comprehensive classification. Remember, 61 is the number given to the pelvic bone. Okay, so A will be lesion sparing with no displacement of the posterior arch. So they are stable injuries. 61B are those with incomplete disruption at the posterior arch. So they are partially stable, or what was we sometimes call rotationally unstable but vertically stable. And type C are where there's complete disruption of the posterior arch where they are both vertically and rotationally unstable. So diagrammatically, the A-type injuries could have A1, where there's an avulsion type of injury in the pelvic bone, type 2, where you have a direct injury of the fracture, and 3 is a transverse fracture of the sacrum or the coccyx. Okay, then we come to the B-type injuries, where you have a vertically unstable, vertically stable but rotationally unstable injury. And this unilateral would be 1 and 2, and if it's bilateral, it becomes B3. Okay, and then we come to the C-type injuries, where you have complete instability on one side or both sides. If it's unilateral injury, it is C1. If it is complete disruption on one side and partial disruption on the other side, it becomes C2. And if there's bilateral complete disruption of the posterior ligaments, it becomes C3. So this is one comprehensive classification, useful for research purposes, and kind of combines the Tile and the Burgess classification and puts numbers onto various grades of injury, as is in all these AO classifications. As you go from A, B, C, it becomes more severe, and as you go from 1, 2, 3, the injuries are more significant. So I think finally, to take home, I think remember, pelvic injuries can be serious life-threatening injuries. I think your initial clinical assessment is important, especially in the emergency management of these patients. The classification should indicate severity and the instability of these injuries, and should also guide you on the management of these injuries. So I think I'll stop there and we'll go on to the discussions. Okay.
So I think one thing which I understood from the talk, or before that, what concept I have is that when it is a lateral compression injury, usually it is the hemipelvis is internally rotated, and when it is anteroposterior API, then it is externally rotated. Is it so, sir?
Well, so in the initial force in the lateral compression is from the lateral side. So that pelvis will tend to get, but if it is a more significant force, then on the opposite side, the injury is the other way around, okay? Yeah, so the force can transmit across to the other side depending on the severity.
Okay, sir.
Yeah, this is classic for rollover injuries, where somebody runs over your abdomen. They hit you from one side, internally rotated, then he hits the other side, the wheel runs over, and it becomes an open book on one side and a lateral compression. So it's a Wim-Strap pelvis.
So, and the most severe injuries very rarely is one mechanism of injury. Okay, that's the other thing. We tend to box them into these various mechanisms, but the most severe injuries are often a combination of mechanisms, because it's very rarely one particular direction of force that causes the most severe injuries.
So we have one question in the chat box, that how is angle of MATA helpful? Do you draw it in preoperative planning?
So the MATA's angles are related to acetabular fractures, okay, not to pelvic fractures as such. So certainly in acetabular fractures, it has some bearing on the management. So you look at the roof arc angle, and the initial original classification was 45 degrees for all the 3 views. I think more recently it's been modified to give a higher degree for the posterior part and the superior part than the anterior part.
And so one more thing which I want to ask is that on the basis of X-ray or in the imaging, do you suspect some type of neurovascular injury, sir? Just looking at the X-ray?
Yeah, so any injury which goes through the foramina, okay, or there is significant vertical displacement. Okay, so all those you have to watch out for neurological injuries. Coxon, anything to add to that?
Yeah, I think the fractures are very doesn't predict injury to soft tissues unless there is a, say, for example, a neurological deficit. say you get a foot drop, and then you see a vertical shear. Then you see the avulsion of the L5 transverse process. You know that there's translational changes, and then you can explain. But just by looking at it, without looking at the patient, you cannot just deduce that he may or may not have neurological or vascular injury. Vascular injuries are even harder because they are usually venous bleeding, plexus bleeding, and fracture surfaces bleeding. So the more displaced you have, the more likely you are to bleed. But you can't tell whether it's an artery or vein until you do angiography.
One question from the Narayan sir. He wanted to know what is military anti-sock trouser.
So masked trousers, as they were called, was a garment which you put on, and then it had a pump mechanism in it which would inflate, okay, and therefore cause pressure on the limbs and reduce the amount of bleeding. But it's more or less been given up today because it tends to cause more damage than good. Okay. It's a way of splinting the injuries by an inflatable pair of trousers.
Yeah, it started in the military because if you think of those NTG suits that pilots wear, they have balloons in the feet, in the legs, and then the thighs, and then the calf. So they will pump blood back to the brain under certain programs. So you are actually exsanguinating the extremity to save the patient by having central pooling of the blood. But if you don't stop the bleeding, you're just causing more blood loss.
And so one more thing which we find difficult to diagnose is a subtle type of vertical shear injury on the X-ray. So just a few clues for that one, sir, for vertical shear.
Coxon, you want to take that?
What you don't understand about vertical shear again?
If it is subtle type, that means if it is
Subtle
minimal.
Yeah. Oh, you mean a subtle type of vertical shear injury?
No, sir.
Subtle type.
Minimal displacement, which usually subtle, is missed.
Well, I mean, if you follow the X-ray pictures that I showed to draw the lines, the horizontal line, the vertical line, you try to find out where the displaced fragment has moved. If it has moved proximally, is a vertical shear. If it has moved laterally, is an open book. If it has moved medially, is an internal rotation or a lateral compression type. So if you see the trick is to look at the iliac crest. If the iliac crests are level, it is unlikely for you to have a vertical shear. However,
so you look at the iliac crest, you look at the sacrum, the SI joints, okay? So if you see any displacement superiorly, then you know that there is a vertical shear. So sometimes in an open back book type of injury, because of the rotation, it will appear that one side is higher than another. So that's something you have to be careful. Always look at the posterior part for vertical displacement.
And another thing, sir, after coming to the, after receiving the patient to the casualty, usually whenever we suspect the pelvic fracture, we used to put a bed sheet around the pelvis before sending him to the X-ray. So as in tile classification also, it is written that 2.5 centimeter and so that may change, sir. So is it acceptable to classify a tile according to tile classification after putting the bed sheet?
So that's one of the problems of using measurements for your classification. Okay, so if you have a disruption of the anterior part, you need to look at what the displacement is in the posterior part. So if it's only anterior, it becomes type A. If it's anterior and the anterior part of the posterior, it becomes type B. And if it is anterior and both sides of the sacroiliac ligament, then it becomes type C. Okay, so the CT will give you, is your guide for that. Okay. And obviously, if there's any vertical displacement, then you know that the posterior ligaments are completely involved. Okay,
yes,
so
it's quite often to have, if you have a pelvic binder or a bed sheet, many open books are actually reduced to the point where you can't really tell whether
exactly.
they are reduced by the bedsheet or there was no minimal displacement. So I always recommend that if you're not sure and the clinical signs of shock and all that, to do a dynamic fluoroscopy. So you do go to the C-arm and then you just put the C-arm and you just do a pelvic compression on the iliac crest and you can see it move. It tells you how unstable the picture, the pelvis is, rather than rely on a static picture.
Yeah, and even the CT scan, when they're doing it, the limbs are internally rotated usually. So they will reduce the amount of displacement of the pubic symphysis sometimes. It will not reduce the vertical displacement, but the anterior opening may sometimes just be reduced by the internal rotation of the limbs to some extent, because you have to get the patient into the gantry, which is kind of narrow.
Yeah. There's a curve support below.
Yeah. And that's a curved gantry, so it automatically tends to kind of reduce the anterior displacement somewhat.
And so in Young and Burgess classification, he has suspected some associated injury, like a head injury is more common with the lateral compression. So in the real terms, how you are looking for that answer when you are receiving the, means according to your experience, is it so, sir, that on the basis of type of fracture?
Sorry, the question is associated injuries, is it?
Yes, sir.
That means if you have a lateral compression injury, should you be looking at a certain pattern?
Yeah, like associated fracture of like head injury, it is in the classification when he is describing. In the paper, they have written that it is more common with the lateral compression. So,
well, I don't know about that, but I think as Dr. John has mentioned, these are usually multiple injuries with multiple forces and sometimes even in different directions. So a person can be tumbling in a vehicle or been thrown out or ejected from a fast-moving vehicle. There will be multiple forces, and there's no, I think to me, no common sense to say lateral compressions have associated with this injury. You have to do the full ATLS examination and pick up separate injuries. You may surmise that it was associated with lateral compression, but I think it doesn't mean that if you have a lateral compression, you are more alert to certain types of other associated injuries.
I think more likely with the severity of the injuries than a particular mechanism, particular pattern of injuries. The severity, that would be more.
Severity is a delta V issue, is a deceleration injury.
Yeah.
The higher the force, the more severe. Whatever injury you get in the head, the chest, is a function of the deceleration force.
So one question from Mithu Kumar Bala from Tamil Nadu. We want to know if taking CT, do the other views such as inlet and jutted view is needed?
I think we discussed this earlier.
Okay, of course, at the end of the care of the patient, you need all imaging. The question is, can you do an X-ray faster or a CT scan faster? If you can do an X-ray faster because the X-ray machine is next to the ER and the CT scan is two blocks away in the radiology suite, then you would do the X-ray first, just to get an idea. Okay, what are the what is the pattern and what is the risk to resuscitation, and what may you plan in the resuscitation. We may even have to do that before you get a CT scan. So it doesn't mean that you're going to wait until the CT scan comes, then you rather have the CT scan, so you avoid the X-ray. So I would always do the X-rays because they can be done even before I arrive. It's a protocol in the hospital. The 5 views are protocol for pelvic fractures, and then when I come, it's already on the digital picture. They send me through the phone, I can see it before I arrive. But CT scan may take some time to set up. They need, patient has to be resuscitated, stabilized, and then you might have enough staff to bring them, to wheel them to the CT suite and all that. So there's a time saving to get the X-ray done.
Yeah, I think today with the newer CTs, you can get reconstructed images to kind of mimic the inlet and outlet views. And so people feel that if they get that, it's not necessary. So again, it goes back to the what Coxon said is the convenience, what is your setup like, and your OR setup, because eventually most of us don't have CT scans in the operating rooms. Okay, so we eventually have to rely on X-rays or the C-arm images, and it's easy to correlate that with the X-rays rather than the CT scans.
And in last, sir, is there any role of MRI scan also?
MRI
Yeah.
For trauma?
Yeah, for pelvic
very
trauma.
little, in the sense that there are a lot of MR unsafe implant, tubes, mechanisms, resuscitation, metallic objects that are attached to the patient when you go for MR. So I think that if they are not MR safe, then it's unlikely that you will get anyone to allow you into the MR room.
Yeah, and so if specifically you need it for the head or the spine, that's a different situation. Just for the pelvic injury, I don't think we would normally want an MRI in the acute situation.
Well, even if you put a C-clamp in, for example, you had to put a C-clamp in the ER, it will not get into an MR machine. So now the neurosurgeon knows that if you got a C-clamp in, they send for a CT with contrast rather than an MR. I mean, you have to compromise in a way. The alternative is to take out the C-clamp and let the patient bleed while they're doing this 1 hour MR, which is not a very good thing to do in an unstable patient.
So how often, so that brings us back to the C-clamp thing. So, I mean, I know at one time there was a big, this thing about using C-clamps, but with the use of the binder, the use of the C-clamp has come down significantly. So what is your indication for using the C-clamp today?
I think that's the next week's topic.
Okay.
Yes, well, maybe we leave it next week.
Yeah, sure, fine. Yeah,
because a talk on that.
Yeah. Okay, great.
Can I say?
Yeah, sure. I will.
Just about the MRI in pelvic injury. In pediatrics pelvic fracture, almost 30-40% get missed, particularly the avulsion type of injury. So, can we ask MRI in such type of cases for investigation point of view? Because with X-ray or maybe with CT, lot of this avulsion type of injury get missed in pediatric, particularly pediatric pelvic injury.
So that is a different situation. Those are often sports injuries. Okay, these avulsion fractures, either of the hamstring or from the anterior of the rectus insertion origin, are sports injuries more than major trauma fracture injuries. Okay, so there definitely the MRI has a role.
This is the pediatric, the classification by the type 1 avulsion injury, pelvic avulsion.
But they often, if you see them, they're often sports injuries, sudden, not major accidents or crushing injuries and things like that. So the mechanism is slightly different. But yeah, there definitely an MRI has a role.
Thank you, sir.
But problem with MRI is basically, see, if you have to do an MRI, you need to have the patient there in the gantry for 45 minutes or an hour. At that time, so it's not a convenient or a viable thing in an acutely injured, unstable patient. So once he's okay, stable, you can take off. If there's any metal things that you get in your way, you can take off. Then maybe if you think you need an MRI, you can do it. But certainly for sports injuries, there's a definite indication for them.
So one comment which comes from Dr. Sudeep Ames Patna, he told that it was just a minute, sir. Okay, sir. So MRI in needs sedation and not that you want to see that, and urging anesthetist and risky. So
yeah, so and well, it doesn't need sedation in adults, but in children sometimes yes, and sometimes even anesthesia in a small child. So yeah.
Yeah, and one more question from Vivek is that is there any study which suggests in which type of pelvic fracture moral laval is most common?
Clearly, lateral compression.
Yeah, so that's one thing, because
Lateral compression.
having crushing of the, and especially these rollover injuries which mentioned, those are the ones where classically you get the Morella Valley lesions.
And sir, a few questions which is mostly I think we'll cover in the next talk. That from Karnataka, Dr. Manjunath has asked average blood loss in pelvic fracture and most common artery involved in pelvic fractures.
Yeah, I think that's going to be covered next time with Coxon.
Next week.
Thank you so much, sir. It was great, and I think next week is more important also to understand. And
Sure.
one more question, I just got it. Why lateral compression test, if done more than once, dislodge the venous hematoma to use, Johnson?
Yeah, so that's why you don't do it again and again. Okay, it's just in your initial assessment to look for any obvious instability in the pelvis. Okay. Okay, and then you would put, especially because very often with the binder on, like in an open book injury, you will not see anything on the X-ray. Okay, so
sir,
it's worth just checking it, looking at the bruising, and then just gently, even just feeling the pelvis to see if there's any instability.
So
doesn't mean vigorous manipulation.
Yeah, you want to ask why it dislodged, sir? Why it happened that the venous hematoma get dislodged by doing the lateral compression?
No, I don't think it's the lateral compression that dislodges, but like if you have a binder and you open it, you're opening out the book.
Yeah.
Okay, so you will give room for the tamponade effect may get lost when the book is open.
So
Okay.
it was great, sir, and thank you so much to you and Coxon, sir. It's great.
Thank you for organizing.
No, thanks, Coxon. Great to have you and great to catch up, even if it's online.
Yeah, it's almost like being there.
Yeah. Okay. Thanks, everybody. Thanks, Ashok.
Okay.
Thanks a lot. Thanks, everyone.
Omnicurious and Ortho TV. Yeah. Okay.
Thank you very much.
Okay.
Thanks,
bye.
sir.